Welcome to Mastering Oral Pathology. Today, we are doing a clinical deep dive that is specially crafted for my dental students. We're going to solve a systemic mystery that often shows up first right in your dental chair. Imagine this. You're examining a patient, and right there on the buccal mucosa, you spot what looks like a totally standard minor aphthous ulcer. You know the one. A painful, yellowish-gray pseudomembrane with an erythematous halo around it. You'd probably think nothing of it, right? I mean, they're incredibly common. But what if that small, localized lesion is actually the first major warning sign of a severe multisystem disease? What exactly connects that simple ulcer to sudden vision changes or even debilitating joint pain? Well, that is exactly what we are unpacking today. We are diving into Behçet's syndrome. This is one of those classic conditions where the oral cavity acts as a direct mirror for systemic health. We're going to focus strictly on the high-yield clinical data so you can absolutely master this condition for your board exams and, more importantly, for your future clinical practice. As future dental professionals, you are in a totally unique position to connect the dots here and raise the alarm before anyone else even notices a problem. Here is our roadmap for today. We'll start with an overview of Behçet syndrome, then move into etiology and pathogenesis, followed by clinical features and manifestations. After that, we'll hit histopathology and immunopathology, cover the differential diagnosis, and wrap up with treatment and prognosis. Section 1. Overview of Behçet syndrome. Let's start with a high-level view of what we're actually dealing with. We have to frame Behçet's accurately right out of the gate, because, guys, this is not just a localized mucosal issue. The absolute most crucial point here is that while those oral manifestations might look like relatively minor nuisance ulcers to the untrained eye, and honestly, a lot of clinicians just dismiss them, they are actually the primary red flag for a much broader, incredibly dangerous systemic issue. This disease can cause absolutely devastating damage across the gastrointestinal, cardiovascular, and central nervous systems. So when you look at a mouth and see severe, recurrent aphthous, your diagnostic radar needs to immediately expand beyond the oral cavity. Think about the rest of the patient's body, because missing this diagnosis can have catastrophic consequences for their overall health. Section 2. Etiology and Pathogenesis. Okay, so let's look at the underlying causes and pathogenic mechanisms that trigger all this widespread inflammation. Understanding the why and how is totally critical for your pathology boards. Now, the exact cause is honestly a bit of a mystery, but we do know definitively that it is non-infectious. It actually stems from immune dysfunction. Specifically, it's an abnormality within the innate immune system where even super minor trauma can trigger a massive, completely disproportionate inflammatory response. Now, what's highly testable and really clinically relevant is its genetic and geographic link. It's closely tied to the HLA-B51 genetic marker. You'll actually often hear this called a Silk Road disease because it's predominantly seen in populations living along the ancient Silk Road, especially folks of Eastern Mediterranean or Turkish heritage. If you have a patient matching that demographic profile and they're presenting with recurrent, severe ulcers, Behçet's needs to jump straight to the top of your mental list. Now, this is the truly fascinating part. This underlying vasculitis perfectly bridges the gap between a simple mouth ulcer and widespread systemic failure. You see, the immune system isn't just attacking the surface mucosa. The inflammation is literally targeting the blood vessels themselves. And because every single organ relies on a healthy vascular supply, this vasculitis allows the disease to travel and indiscriminately attack cardiovascular and neurological tissues. It's basically a systemic vascular fire. Those oral ulcers, they're just the sparks we can easily see on the surface. But beneath that, the microvasculature of the entire body is under siege. Grasping this vascular mechanism is the absolute key to understanding everything else about this syndrome. Section 3. Clinical Features and Manifestations. All right, now we reach the core of what you'll actually observe in your patients. This is where your clinical detective work truly kicks in. Look at this number, 100%. This is exactly why dentists are the absolute first line of defense. A full 100% of Behçet's patients present with minor and sometimes major recurrent oral aphthous. You're typically going to see these lesions distributed right across the non-keratinized oral mucosa, so the labial and buccal mucosa or the soft palate. And listen, these aren't just occasional sores. They recur with intense frequency, often showing up in multiples. Because the incidence of these oral ulcers is universal in this patient population, you simply cannot afford to ignore a history of recurrent aphthous when a patient is sitting in your chair. But we have to look beyond the oral cavity and consider other mucosal surfaces too. 62% of patients will also suffer from really painful ulcerative genital lesions. This just highlights the severe mucocutaneous nature of the disease. Now, obviously, as a dentist, you won't be doing a physical exam of those areas, but This is where taking a thorough, careful medical history is essential. You might be wondering, how do I even broach that topic? It's simple. During your medical history intake, just politely and professionally ask, hey, in addition to these severe mouth sores, have you experienced any similar lesions or discomfort in the genital region, or noticed any recent changes in your vision? Asking those targeted questions gracefully is exactly how you guide your patient to the correct systemic diagnosis. And the answers to those questions might reveal the multisystem nature of the disease, moving way beyond the mucosa. Let's break down the sheer weight of this assault. Ocular involvement, incredibly common and highly dangerous. Patients experience severe inflammation like uveitis and retinitis, and if left unchecked by a physician, that carries a devastatingly high risk of permanent blindness. Articularly, they might complain of recurrent aching arthritis in their wrists, ankles, or knees, often mimicking rheumatoid symptoms. Remember that intense underlying vasculitis we just talked about? Well, because of that, the cardiovascular system is highly vulnerable, putting these patients at a severe risk for deep vein thrombosis. And if that vasculitis reaches the central nervous system, it can trigger debilitating headaches, neurological deficits, and even fatal infarcts or strokes. Finally, they may present with painful pustular erythema nodosum-like skin lesions on their extremities. It's a comprehensive, whole-body crisis. Here is a great mnemonic for your exams. Remember that when Behçet stigmata are combined with relapsing polychondritis, it's designated as MAGIC syndrome. MAGIC literally stands for mouth and genital ulcers with inflamed cartilage. To visualize this clinically, a patient with relapsing polychondritis might present with a severely swollen, red, and exquisitely painful ear, or they might develop a saddle nose deformity because their nasal cartilage is being destroyed. It's an incredibly useful memory hook when you're trying to differentiate complex, overlapping syndromic presentations on your boards. Section 4. Histopathology and immunopathology. So let's look under the microscope and see the cellular data that actually confirms our clinical suspicions. When you send a biopsy to the oral pathology lab, this is exactly what we are looking for. Because routine laboratory blood studies unfortunately give really non-specific results for Behçet's, noting this exact methodical sequence of vascular targeting on a biopsy is absolutely critical. First, we'll see a prominent T lymphocyte infiltration in the ulcerative lesions. These are your initial immune responders, recruiting the inflammatory army. This is then quickly followed by neutrophilic infiltrates appearing directly within the vessel walls, which is the physical manifestation of that active vasculitis. Finally, the immunopathologic support comes from demonstrating immunoglobulins and complement deposited right inside those vessel walls. That complement deposition is what actually drives the structural necrosis of the blood vessel. This whole sequence definitively proves that the microvasculature is the primary target of the attack. Section 5. Differential diagnosis. As a dental professional, you absolutely must be able to differentiate Behçet's from other conditions that present with similar oral lesions. A misdiagnosis can delay critical systemic treatment, so let's sharpen those diagnostic skills right now. First up is Reader's syndrome, which is a form of reactive arthritis. While both of these can present with a triad of oral, ocular, and joint issues, there are some major key differences. Reader's syndrome typically strikes young men following a very specific bacterial infection, like dysentery or chlamydia, whereas Behçet's has no known infectious trigger. Genetically, Reader's features the HLA-B27 genotype, which is completely distinct from the B51 we see in Behçet's. And visually, this is your bread and butter right here. The oral lesions in Reader's often resemble geographic tongue, presenting with irregular zones of erythema and raised serpentine borders. Behçet's, on the other hand, almost exclusively presents as standard well-defined aphthous ulcers with a necrotic center. It's also super vital to distinguish Behçet's from complex aphthousis. Now, complex aphthousis features both mouth and genital ulcers, which might initially make you strongly suspect Behçet's. However, complex aphthousis entirely lacks the ocular, arthritic, cardiovascular, and neurological dangers. This once again highlights the absolute critical importance of a thorough medical history. If your patient has the mucosal ulcers but zero other systemic components after a really thorough workup, it's complex aphthousis, not Behçet's. You have to ask the right questions to rule out the systemic dangers of the former versus the localized annoyance of the latter. Section 6. Treatment and prognosis. Finally, let's review the pharmacological strategies used to manage this complex condition. While you obviously won't be prescribing these systemic drugs as a dentist, you absolutely need to know how these medications impact your dental treatment plan. Management requires a highly tailored, tiered approach. It often starts with systemic corticosteroids as the primary intervention, just to rapidly quench the inflammation. From there, rheumatologists might escalate to heavy immunosuppressants like chlorambucil or azathioprine, and in really severe cases, biological anti-TNF agents. Now, why does this matter to you? A patient on heavy systemic corticosteroids is at high risk for adrenal suppression and opportunistic oral infections like candidiasis. Furthermore, if you're planning an invasive procedure like an extraction for a patient on biological anti-TNF agents or heavy immunosuppressants, their healing capacity is significantly compromised, and their risk for severe postoperative infection just skyrockets. Knowing this medication list dictates that you must consult with your rheumatologist. It will likely alter your surgical approach or have you utilizing prophylactic antibiotics. I hope this breakdown has shown you exactly why every thorough oral exam is a window into systemic health. A simple ulcer is never just a simple ulcer until you've actively ruled out the broader, potentially life-threatening picture. I want to encourage you to keep questioning what lies beneath the surface of those everyday lesions in your clinic. How are you going to adjust your medical history taking tomorrow to ensure you aren't missing the next case of Behçet syndrome? Keep that in mind, stay sharp out there, and I will see you in the next session of Mastering Oral Pathology.